Good morning, everyone, and welcome to the 12th Annual Women's Health Research Day. We're hosting this at the Center for Women's Health Research, but virtually, and the Center for Women's Health Research is at the Anschutz Medical Campus of the University of Colorado. I'm Dr. Judy Regensteiner, Director and co-founder of the center. At the Center for Women's Health Research, we envision a future in which research includes women and accounts for sex and gender differences, shaping better health for all. We're making this vision a reality by funding and mentoring the next generation of researchers and sharing our learnings with the community through outreach and education programs. The areas of focus are cardiovascular disease, diabetes, and the intersection of mental and physical health, all issues that pose significant threats to women's health, really, as well as to men's health. Women's Health Research Day is an annual celebration of women's health and sex and gender differences research. Thank you all for being here today, and thank you for recognizing that it is critical that we consider including women, and women should be included in all studies, except for very few where there's, like prostate cancer, but women should otherwise pretty much be included in all studies. And we also consider sex and gender in our research and our care for patients. In a normal year, we have a whole celebratory day on campus to hear from a national leader in women's health, like we are today, only it's in person, and with snacks and refreshments. Sadly, today we are not having snacks and refreshments and we're not able to be in person, but we're hoping for our next event to be in person. Normally, we'd also have a judged poster session. Due to all events being held virtually at this time, there will not be a poster session for this event, but there will be one at our national conference in August of 2022. So to jump right in, today we are honored to host Dr. Patricia Gabow as our keynote speaker, and it is my great pleasure to introduce her. Dr. Gabow spent her medical career at Denver Health, where she served as CEO for 20 years. She is a professor emerita of medicine at the University of Colorado School of Medicine and a master of the American College of Physicians. She has authored over 170 articles, book chapters, and books. Her most recent book is Times Now for Women Healthcare Leaders, A Guide to the Journey. She was a founding member of the Federal Medicaid and CHIP Payment and Access Commission, serves on the board of trustees of the Robert Wood Johnson Foundation and Loan Institute, and has received numerous awards, including from the National Academy of Science, which is the biggest scientific body in the country, or the most important scientific body in the country. Today, Dr. Gabow will speak on women in American healthcare, problems and promise. There will be a Q&A session at the end of Dr. Gabow's talk. Please type any questions you may have during the presentation into the Q&A box at the bottom of your screen. We will not take questions during the talk, but immediately thereafter. It's now my honor to turn over the virtual podium to Dr. Gabow and thank her for joining us today. She has had an eminent career and continues to contribute greatly and eminently. So thank you, Dr. Gabow.
Well, thank you, Dr. Regensteiner, both for the invitation and for that nice introduction. So let me share my screen. Before I begin, let me explain my voice. I have spastic dysphonia, and the treatment for it is Botox, but does nothing for my wrinkles. As we begin to discuss women in American healthcare, we have to realize that healthcare is not standalone. It is embedded and influenced by the culture and society in America. So we have to look at the role of women in American society. This bold experiment in democracy started with the declaration that all men are created equal, and that meant white men. It took 150 years for women to be able to be participants in this democracy. Shortly after women's suffrage, a movement began to add an Equal Rights Amendment to the Constitution. It took 50 years for Congress to pass the ERA, and today we are still not, we still don't have that constitutional amendment. In the 60s, it became clear that women were not paid equal to men. And the Fair Labor Standards Act was amended to achieve that. But still today, we do not have pay equity. So in this country, women are not equal to men. And this is underscored by data from the World Economic Forum, which looks at gender equity through domains of education, health, economy, and politics. And although we are the richest country and therefore should be most able to create gender equity, we are not among the top. In fact, we rank 45th among the countries in gender equity. With that background, let's look at women in healthcare in the domains of recipients of care, caregivers, workforce, and leaders. As we think about women as the recipients of care, we need to look at conditions unique to women, how they are treated for common diseases, and their access to medical breakthroughs. I would say that the best reflection of how society and healthcare treats women is to look at how women are treated before, during, and after pregnancy. It took until 1965 for the United States to legalize contraception, far behind other developed countries. And then it was only for married women. Only with the ACA did contraceptive care become free for women. And currently, reproductive care is under attack on many fronts. The story of maternal health is a mixed one. In 1900, 850 women died per 100,000 live births. In the early 1900s, there was tremendous improvement. And by 1987, that number was 7.2. But unlike other developed countries that continued to improve maternal death rate, we got worse, so that by 2019, 17 women died. And that number belies the reality that there's enormous variability by race and geography. Black and brown women have a 2 to 3 times mortality rate and a 5 times morbidity rate compared to white women. And there is huge geographic variation, with the 5 worst states in the United States having mortality rates of between 36 and 58 women dying per 100,000 live births. That's equal to what is seen in Jordan and Vietnam. In fact, we have one of the worst, if not the worst, maternal mortality rates in high-income countries. This is clearly unacceptable. Dr. Regensteiner and Dr. Epperson, who are part of the center, were part of this study looking at the most common disease, heart disease, which is the leading cause of death in the US. Women with ischemic heart disease are underdiagnosed, less likely to see a cardiologist, receive evidence-based care, have pre-hospital diagnosis, receive reperfusion or a heart transplant. Interestingly, they are more likely to be heart transplant donors than a man. As we think about women's access to medical breakthroughs, we need to look at 2 issues: women as research subjects and women as researchers. What clinicians know about the diagnosis and treatment and prevention of disease originates from studies mostly done on male cells, male mice, and men. Not only is this an issue of gender equity, it is not good science. But this is an area where some progress has been made. For decades, women were excluded from clinical trials for a variety of reasons. One, they could be pregnant and the fetus could be affected. Their hormonal variation was a confounding variable, making trials larger in size. And of course, men were doing most of the research. This exclusion led to failure to address conditions unique, such as pregnancy, or more common in women. It also resulted in a failure to address different responses to conditions or drugs in women. An example of this is that 7 of the 10 drugs withdrawn by the FDA from 1997 to 2001 had a greater negative impact on women than men. But as I said, this is an area where progress has been made. The women in Congress demanded that this change. And in 1986, Congress and the NIH began to require the inclusion of women in late phase trials. Shortly after that, the establishment of the Office of Women's Health in NIH occurred, and the Women's Health Initiative came into being. And that had major impact with studies on postmenopausal estrogen, breast cancer treatment, and HPV vaccine development. This went on to have the NIH mandate inclusion of women in all NIH clinical trials. And in more recent years, NIH has advanced their work in sex as a biologic variable that had to be accounted for. This was further enforced by the 21st Century Cures Act, which also put a spotlight on maternity care. By 2017, 50% of the participants in NIH-supported research were in fact women. However, there is still variability in the inclusion of women in certain trials and in the analysis of studies by gender and sex. The other part of women having access to medical breakthroughs is women as researchers. There is a strong suggestion that women are more likely to investigate the issues that affect women's health. So it's good news that 33% of the NIH grants are now awarded to women, although the increase has been slow. Overall, the grants are about the same size, but not all is good news. Women apply less often for initial awards and renewals than do men. There are a variety of reasons for this, but one is that women entering academic medicine have smaller startup packages than men, even when you correct for relevant variables. And this may have the effect of not having them ready for initial awards. How important institutional support is shown by this Center on Women's Health Research, which invested $1.8 million that turned into $92 million in grant awards. Let's look at women as caregivers in society and in the healthcare workforce. Women make up 75% of all the healthcare decisions made for families. A mother is 4 times as likely as a father to stay home with a sick child, and 75% of the care given to adults in a family is given by women. This may be rewarding to women, and it surely is, but it places an additional burden on them. This is true even for professional women. A study by Jolly showed that women physicians with children with a male spouse or partner spend 8.5 hours more per week on childcare and domestic activity than do the male partners. In essence, women have a 6-day work week compared to the 5-day work week of men. And that 6th day is unpaid. Women form the backbone of American healthcare, as is shown on this slide, which gives the gender distribution of the major healthcare professions. Women are the majority. They make up 95% of midwives, 88% of the nurse practitioners, 87% of the occupational therapists, 86% of the registered nurses, who are the single largest group of health professionals in the country. In fact, the only 3 professions which are under 50% are physicians, dentists, EMTs, and paramedics. And when you look at this overwhelming predominance of women in the health professions, you would assume, therefore, that they must be the leaders in American healthcare. This is far from the truth, as is shown on this very steep pyramid. Women are 83% of the frontline healthcare workers, but they're only 30% of the C-suite. And even in the C-suite, they are not the most influential positions. They are not the CFOs. They are not the COOs. Even if you look at chief nursing officers, where the profession is almost 90% women, only 60% of the CNOs are women, and only 13% of healthcare CEOs are women. And the crosshatched area shows what would have to be added to create equality. Academic medicine looks very similar. We've solved the pipeline issue with over half of medical students being women, and 59% of instructors are women, but only 25% of professors, 16% of chairs, and 15% of deans. And here again, they are not the top dean positions. The increase in chairs and deans has been very slow, less than 1% per year over the last 10 years. Let's look at chairs in relationship to the pipeline. The top 5 disciplines for women in healthcare are pediatrics, dermatology, pathology, OB, and family practice. Despite having many women residents, less than 30% of the chairs in these disciplines are women. OB is a startling example, where over 80% of the residents are women, but less than 30% of the chairs are women. So it's very clear from this data that women are significantly underrepresented at the tables of healthcare leadership. I'm not asking, should this change? Because the answer to that is obviously yes. But I will ask, why should we change this, and try to give you some data to support the reason for change. American healthcare has major problems that must be addressed. It's a matter of simple fairness, and women add valuable skills and essential perspectives. I don't need to tell this group about the problems in American healthcare. I will just quickly say we have too much cost, too little access, not the greatest outcomes, and marked disparity across many domains. While I don't blame this on men, it is a fact that all the tables of healthcare leadership for decades have looked like this. They are all men and mostly white men. And I would posit that the same people at the table will continue to get the same results. We need diversity at the tables of healthcare leadership. We need men and women, white individuals and individuals of color, seniors and young people. Different leaders with different perspectives will yield different results, and I would posit better results. It's also a matter of fairness. Fairness demands equality, and equality demands equity. We often use these terms interchangeably, but they are different, and the difference matters to women. It's shown quite clearly on this cartoon from the Robert Wood Johnson Foundation. With equality, everybody gets the same bicycle, but only one person can ride it. And in fact, that's actually the man. With equity, everybody gets what they need to accomplish the task. If we're going to have equality for women, we must create equity, which means leveling the playing field. We're the child bearer, so women need paid maternity leave. We do the most child rearing, so women need affordable quality childcare. We do the family caregiving, so women need paid family leave. And we need income equality, so we have the resources for all of the other three issues. So how does the United States do in these areas? We are the only one of the 35 OECD countries that does not offer paid maternity leave. And many of those countries, it's very generous in terms of months and even a year. We have the second highest childcare costs of all OECD countries, meaning many women can't afford childcare, let alone quality childcare. And this includes professional women. What about healthcare? There is very little data on how healthcare deals with these equity issues. A small study of 12 medical schools showed they all had faculty maternity leave that varied from 6 to 16 weeks, but it was at the auspices of the chair. Women make up 47% of the residents in American healthcare, and they're in their childbearing years. But just now, training programs of 2 or more years duration will give a minimum of 6 weeks for parental, caregiver, or medical leave without an extension of training. There are still many questions. For example, does this 6 weeks include their vacation time? And for those who have had children, we know this is not a period of vacation. We have no data on other trainees or students. In addition, and perhaps most importantly, women add valuable skills and essential perspectives. What's the source of that perspective? Well, some of it is what I've told you, and it's captured in these quotes from women I interviewed. Women see 2 generations of care, children and adults. This helps us see the need for longer term solutions. Women are the coordinators of care. This gives them a broader perspective of the healthcare system. They see the gaps. You better recognize that women are in charge at the customer level. And if you are not meeting the needs of women, you are missing the boat. but women bring more to the table than perspective. Goldman Sachs ran a full-page ad in the New York Times asking, what changes when a woman leads a business? And their answer was everything. And for a firm like Goldman Sachs, everything means profitability. While there is not data looking specifically at healthcare across all domains of business, there is robust data that companies with the highest percentage of women officers have substantially higher ROI and total return to shareholders compared to those with the lowest percentage. Firms with at least 30% women leaders compared to those with none added 1% to the net margin. Now, that may seem like a small amount, but it was a 15% improvement over the average. And companies with a female CEO or CFO outperformed the market average and their male counterparts. That's the good news. The bad news was when the skill set of these women CEOs and CFOs was examined, it was equal to the very best men CEOs and CFOs. So the women had to be the best to get the job in the first place. But it goes beyond profitability. This is a study from Zenger Volkmann, which is a consulting company that assessed 7,000 men and women managers and executives from high-performing companies using their 360-degree evaluation. And they showed that women scored significantly higher than men in integrity, taking initiative, driving for results, self-development, establishing stretch goals, championing change, inspiring and motivating others, building relationships, collaboration, and teamwork. And you look at this list and you say, what's missing? I would say not much, if anything. Integrity deserves a special comment. Women value integrity. In fact, this study and others have shown that women will not sacrifice their integrity for a significant promotion. One reason women in academic medicine give for not pursuing leadership is they believe they would have to compromise their values and integrity. This is a sad commentary on academic medicine, but I would posit that this issue of integrity is the reason why women should get into leadership positions. Zenger Volkmann had two conclusions. Women clearly have an advantage in people relationships and communication, which I would say is very important in healthcare, and that they're adding more women to leadership increases the overall effectiveness of the team. One question that we should ask is population health better with women healthcare leaders? We don't know the answer to that, but there is a suggestion that this could be the case if we look at women physicians who positively impact patient care in a number of ways. Women physicians spend more time per visit with their patients, resulting in a more thorough history, more diagnoses, and shared decision-making. They have more patient-centered communication, are more likely to follow evidence-based care and provide preventive care, and have better clinical outcomes, even lower mortality in some recent studies. So if women bring so much to the table of leadership, why does the picture look like this? And the answer is that women face significant barriers to obtaining leadership. The two principal ones are gender bias and sexual harassment. And these intersect. A culture with gender bias is a fertile ground for sexual harassment, and together they lead to increased incidents of burnout and imposter syndrome in women that in itself can keep women from leadership roles. Let's look at gender bias. Women experience bias in language, about their behavior and appearance, in hiring, promotion, and pay. And there is a strong intersectionality between gender and race. Language is one of the most powerful means through which sexism and gender discrimination are perpetuated and reproduced. Men are referred to as independent, forceful, confident, and ambitious. And these are the words that are linked to leadership. Women are referred to as warm, caring, generous, kind, helpful, benevolent. And while these may be very important characteristics in healthcare, they have a negative connotation for leadership. And women get a double whammy. If they're referred to with male words like independent and ambitious, that also is negative. We have got to get to a point where these words do not put fences around how men and women act. Men leaders have to be able to demonstrate warmth and caring, and women leaders need to be able to manifest independence and authority. It goes beyond words. Letters of recommendation are critically important in getting jobs and promotions. Yet women at a higher percentage of shorter and men a higher percentage of longer letters. Women's letters refer to teaching and training, while men's letters to the ability and research. And there were more doubt-raising phrases like, oh, she could be good, the old damning with faint praise in women's letters. And although doubt-raising phrases hurt both men and women, since they're more common in women's letters, they have a greater negative impact on them. Even simple introductions. Women introduce male speakers using a title 95% of the time, where men introduce female speakers using a title 49% of the time. One of the worst consequences of bias is pay inequality. And this inequality is across all the health professions, but I'm going to talk about physicians because they have the highest gender pay inequality of any profession. Overall, women physicians earn $90,000 less per year than men. In academics, a female academic physician earns between $20,000 and $51,000 less than male physicians. And 40% of that difference isn't explained by any reasonable adjustment. The adjusted salary for a female associate professor is equivalent to a male assistant professor. And since that journey takes 7 years on average, women are penalized 7 years of their working lives. The female full professor is equivalent to a male associate professor. And even at the chair level, there's a significant difference by gender. This slide should make you gasp for several reasons. This shows the top 4 earners of male CEOs and female CEOs of health systems. First of all these salaries are outrageous, but it is amazing the difference between the female leaders and male leaders. The AAUW did a very simple study. They took the average difference per year in a woman physician's salary times the number of physicians and said women are losing $19 billion a year. If you looked at all the health professions, this difference could almost equal the national debt. One pay difference that is particularly disturbing to me is the motherhood penalty. Mothers earn less than fathers, regardless of their education level. And over the last 20 years, women's education and experience has increased, but the motherhood penalty has also increased. And for every child a woman has, this penalty increases. This is clearly unacceptable. What about sexual harassment? The academic workplace has the second highest reported rate of sexual harassment, just below the military. And this starts from the beginning with 20 to 40% of undergraduates and graduates, 50% of medical students, 20% of surgical residents. It doesn't go away with faculty, and it isn't unique to physicians. It occurs in 21% of nurses. But the times, they are changing in culture, politics, business, and healthcare. In culture, the Me Too movement and Time's Up reflects that. Of course, baseball is a male bastion, and a major cultural change was Kim Ning being appointed as the first female manager of a Major League Baseball team. A record number of women have run for office, and there are 126 women in Congress, most Democrats, 9 women governors, and 31% of state legislators, including the majority in the House in Colorado. And this matters because this is where laws are made around Medicaid, around contraception, around pay. Perhaps the greatest achievement politically was Kamala Harris being the first elected vice president of the country. Now, both Kim Ning and Kamala Harris certainly deserved these positions, but it's important to remember that these men opened the doors for them to reach these positions. The business community in America is incredibly powerful. So when the Bloomberg Group said gender inequality is one of the most critical challenges facing both public and private sectors globally, it has never been more critical for a company to demonstrate how they're advancing women. This is worth noting. But they went beyond this statement, and they formed a group that looks at 5 dimensions of advancing women. And the companies that join report this publicly and share best practices. They have 325 members, 4 healthcare groups, but sadly, no healthcare systems. However, women are now leaders of some very prestigious healthcare systems in this country, including here in Colorado, and they are CEOs of some important healthcare companies. So the glass ceiling is breaking, but you see, a woman has to push her hand through. And women sometimes make barriers for themselves, and they self-eliminate from positions. Why do they do that? Well, this study asked the question to men and women, why didn't you apply for that job? And while they differed in a number of areas, women feel they have to check every box. And equally important, they didn't want to take a risk. They didn't want to put themselves out there, and they might fail. Now, you know the story of the man shaking his fist for not winning a lottery, and a voice booms, buy a ticket. Well, if we want women in leadership, they need to buy a ticket and apply. They might not always get the job, but they could find themselves in the corner office. And certainly women now have made great advances in culture, in government, and in business, in healthcare. Pinker pointed out that it's the nature of progress that it erases its tracks, and its champions fixate on the remaining injustices and forget how far we've come. We can't forget how far we've come, and these women who have broken the path and the men who have helped them. But we have to think about dealing with the remaining injustices. Going forward, men and women must see the current situation as unfair, inequitable, and most importantly, limiting the ability of healthcare in the nation to solve our problems. Men and women must work together for change, and change requires action by governments, institutions, and individuals. Institutions have to eliminate bias in language, hiring, and promotion, and eliminate sexual harassment and require transparent accountability of perpetrators. They need to institute equitable policies around parental and family leave and affordable and accessible childcare, create pay equity and complete pay transparency. Mentoring and sponsorship is important for the advancement of men and women, but it can't be haphazard. It has to be formalized. And we must require monitoring and reporting of progress in all of these areas. Let me conclude by saying gender equality in healthcare and in its leadership is in itself a worthy goal, but the full promise of women's equal role in healthcare will be in their facilitating a transformation of American healthcare into a fairer, more caring, and more open system for all Americans. I believe this is a contribution that women can and should make to our nation. Thank you very much. I'm glad to answer any questions.
That was wonderful, Dr. Gabow. That was a lovely and impactful talk, and I really appreciate it. I'm pleased that at the Center for Women's Health Research, we have many strong male allies, and it pleases me because together we're better together. We can do more with such allies. So I think that's an important point. One question I have for you, and then we have many other questions, is it seems people are talking now more, thankfully, about increasing diversity, not only improving gender equity, but also for people of color. I think this is critical and has to happen, but it can be hard in a state like Colorado where there may be less diversity. What are some early steps that one could take to make sure that this happens?
Well, I think it was listed on that next to the last slide. I think that you have to get rid of bias. And how do you get rid of bias? Well, first of all, we have to acknowledge that we all have implicit bias, and we shouldn't feel like guilty about it. It's part of being in society. You get implicit bias, but we all need to be trained about it so we understand that we have it so we can deal with it. And how you deal with it matters. I mean, of course, we're all biased towards our own children. That's good. But when they're applying for a job, that's bad if we're making the decision. So we have to understand that better. And that requires training, and it requires procedures around committees. Promotion committees, hiring groups, search committees, so that they know from the beginning how they're going to deal with these issues. And we also have to start with pay equity. Any organization that is not transparent about their salaries and is not committed to pay equity needs to be held accountable. And women and men need to stand up and say, this is unacceptable. And those are two important places, I think, to start.
Thank you. Dr. Ann Libby, senior scientist for the center, asks or notes that women need to get hired appointed into leadership positions, yet we know that there is unconscious bias in evaluating readiness to lead. What is your advice for how women can compete at the application and interview stages of leadership opportunities?
Well, I think I just addressed a little bit of that, is that you do have to make sure the search committees have balance racially and gender-wise. They need to know from the beginning what their characteristics are they're looking for, so that there's a template starting out. And I think that it helps if they have more than one candidate for a position. It's been shown that if a search committee has two women applicants they're considering, it's more likely that a woman will be hired than if they have just a single, maybe token candidate. So that's important. I think one of the most important things for women to get into leadership positions is mentoring and sponsorship. And, women need to ask for their mentors and sponsors. If you sit in your office and think someone's going to come by and say, I've been thinking I'd like to be your mentor or your sponsor, it's never going to happen. And you need to decide, do you want a woman or a man mentor? Do you want someone from your own institution, or can they be somewhere else? Right now, because most leaders with influence are men, and influence matters in sponsorship, most women may want to have a male sponsor at this point, although mentorship doesn't require that level of influence to have. But I think, and institutions need to formalize that mentorship and sponsorship. It can't be random. The business community is doing a very good job in that. And it's important that it's formalized, because men have a network already that helps them get mentors and sponsors. And if it's not formalized, women have a disadvantage in getting a mentor and a sponsor.
Thank you. Dr. Jane Roosh, who is Associate Director of the Center and also a Senior Scientist for the Center, says, thank you for this impressive and distressing review of the landscape. Can you please dive into your thoughts on the timing of interventions for pay equity for women? And you mentioned one at the beginning, salaries should be transparent, but she would like more talk or more discussion of that matter. Her question surrounds making sure that women start with pay equity.
Yes, they do. And I have a bias about this issue. Some people will say, well, women need to be trained to negotiate because they tend not to negotiate for themselves. At Denver Health, we had no negotiation. Pay was based on your years out of training, the discipline you were in, and what your leadership position was. And we did a pay survey every year across all the domains, so we had good data. And we didn't negotiate with people coming in. If you were in bin X, that's what you got. And it actually helped us hire women. I just talked to one of our current chairs at Denver Health who said he interviewed a woman recently, and she said, well, how will I know I'm being paid fairly? Are women paid fairly here? And he described our system, and that was a recruiting tool. And the Michigan, there's a system in Michigan that uses the same thing. We have to get away from negotiating salaries because it will never be fair. We need a structured way to pay people. And that needs to start with hiring and with promotion. And we will never have pay equity if salaries are kept secret. Every salary has to be transparent. And then people have to be called out when there are huge discrepancies. And this is just outrageous. Women overall in this country are making 80 cents for every dollar that a man makes. And this can't be.
Dr. Alexandra Orahovets, sorry if I mispronounced it, asks, are there any thoughts on the reason why women of color are disproportionately likely to die postpartum from unexplained causes? Why don't we have more research funding devoted to this?
Well, I think, as I pointed out at the beginning, our maternal mortality is abysmal when you think about the money this country has, and it's largely been ignored. And I don't think we have good information at this point on why we have the disparity by race and ethnicity, nor why we have the disparity by geography. I mean, if you look at the difference between Alabama and Colorado or California and New Jersey, it's shocking. And why is this? And we just have to have more research about it, and we have to cover it better. I mean, Medicaid is really an important maternal benefit, and more than 50% of all deliveries in this country are paid for by Medicaid. But having sat on the Medicaid Commission, I can tell you that what is covered in Texas is not the same as what is covered in Colorado. And the coverage postpartum is abysmal in many states. And we have to deal with that, because many poor women and many women of color are getting their care out of Medicaid. And that is where we have to start, I believe.
I have a question from Dr. Neil Epperson, who's chair of the Department of Psychiatry and also a senior scientist for the center. Dr. Epperson says she's presenting to our state legislators and has the opportunity to highlight many of these issues. What she would like to know is whether there are academic medical centers who are providing more progressive maternity leave and childcare policies support. It would be wonderful to get a coalition of these centers together so that we can learn from each other as to how to build change into individual institutions' departments. I am sure that the AAMC has a major role here, but I would find it helpful to hear from chair colleagues, as we often run into problems if we try to do something progressive department by department. Yet, of course, she does not have control over the entire School of Medicine or the CU Anschutz Medical Campus. She's not sure how to change payments for maternity leave, et cetera, even though they have done a gender equity upgrade in her department on salaries.
Well, I think it's sad that it's hard to get this data. I mean, I showed you what I think is out there, Jolly from 2014, looking at 12 public schools. But I do believe that people can start where they are. One of the important things about leadership is to lead from where you stand. And David Schwartz in the Department of Medicine decided a while ago that there wasn't at that time parental leave at the University of Colorado Medical School and health system. And he started to use department funds to do that. And it led to the school making some changes. So I do think that everybody has to start from, everybody has to lead from where they stand. And if we wait for change at the top, sometimes that doesn't happen. I think we're lucky that the legislature in Colorado, and I'm glad you're testifying before them. I think the fact that there are a lot of women in the legislature is why we got paid family leave moving forward. And I think that this is important to move the legislature along. but we have to demand it out of our institutions. And as long as people are silent, and it doesn't matter whether that's with things that happened at the Capitol last week or in our own institution, silence will never bring about change.
Dr. Wendy Court, Associate Director of the Center and Senior Scientist as well. In evaluating candidates from leadership positions, do women hold female candidates to a higher standard than male candidates? So is there bias on the part of women as well as men?
Well, there certainly are women who have the queen bee syndrome. There's only going to be one of us in this hive, and women can in fact be a barrier to other women. I think that's changing a lot, but women also can help other women. When I was CEO at Denver Health, if you look at our executive team, the chief nursing officer was a woman. The chief operating officer was a woman. The CFO was a woman. The head of government relations was a woman. The chief communications officer was a woman. The head of our foundation was a woman. The head of our health plan was a woman. So, and I don't think that we were biased to hire women, but we weren't biased against hiring women. And so I think, not all women are the same, not all men are the same. And certainly some women demand more of other women, but that's not always the case. And I would say it's not usually the case.
Dr. Allison Haru from the Department of Psychiatry says, you say that you think having women in leadership will lead to more open, healthcare being fairer, more caring, and more open. Do you have evidence that this is so? I assume that you do.
No, as I said, there is no data on that, partly because there's so few women right now leading institutions. But the data I presented, which I think is suggestive, is if you look at women physicians and how they manage patients versus men, there is a suggestion that there is a different perspective. And I think that if that's true one-on-one, when you're at the bedside of a patient, it should be translatable to a population when you're leading an institution. Now, again, we have no data, but I would say that if women in leadership don't change American healthcare, then we won't have realized the full potential that women can bring to the table. And the data I showed you about perspective and the fact that women do the child care, they do the adult care, they're making the family healthcare decisions. And as the women I quoted say, we understand the gaps. So why wouldn't we be more committed to fix them? I mean, we don't have the data, but it's a reasonable hypothesis.
I have so many questions. I'm going to go over our time, just a couple of questions, and then we'll move on to our next session with our junior early career scientists with Dr. Gabow. Dr. Chris Hadley asks or notes, Dr. Gabow, when you became the CEO of Denver Health, you built a tremendous reputation of respect, success, and leadership. How did you build that reputation as the leader and CEO of Denver Health?
I had a great team. I mean, in all seriousness, if you think you're going to accomplish anything important by yourself, dream on. You need a great team. And it's interesting, given the fact that we had that predominant women's leadership. I asked for my book, I interviewed a number of the male leaders who reported to that team and asked, what did you think about having a predominant women's leadership team? And their answer was enlightening. And they said, well, first of all, we think a safety net institution is committed to equity and therefore more open to women's leadership, and that women leaders are more committed to equity and openness, and therefore it becomes a self-perpetuating cycle of good. And and they thought that when that wasn't the case, Denver Health didn't do as well. So that's, again, indirect evidence about women in leadership changing healthcare. And the other thing is we all have to be authentic and be who we are. And we have to always say the same thing. I mean, I perseverated on the same issues for 40 years. And, you know, as long as you keep saying the same things that you believe them and you have a great team, then you can do these things.
I will take one more, or give you one more question from Dr. Amy Keller, who notes that, as you mentioned, the motherhood penalty continues to be a huge barrier to women's careers this year, especially. And that's an understatement. What are some equitable solutions to this penalty?
It gets back to you can't negotiate salaries. You have to be transparent about salaries at every juncture, hiring, promotion, etc. And we have to do what I said. You know, every other developed country has paid maternity leave, has good childcare, subsidizes that childcare. I mean, you know, if we just look at the percent of children, 3-year-olds who are in school, the United States is below Mexico. And so, you know, if we don't think about childcare and early childhood education and maternity leave and parental leave, you know, these penalties are going to stay and they're unacceptable. But we have to point them out and we have to ask for the data. Dr. Epperson said about the AAMC. Well, everybody on this call who's in a leadership position should send an email today to the AAMC and say, we want to see this data for all academic medical centers. I mean, I've asked for it, but I've never seen it.
The AAMC, for those of you who don't know, is the American Association of Medical Colleges. Well, we're going to wrap up Women's Health Research Day's presentation. I want to again thank Dr. Gabow for her insightful and excellent presentation. Thanks to all of you for attending and participating in the Q&A. There are still many questions, and I'm sorry, but we have another event now with our early career scientists.
But I gave you my email, and feel free to shoot me an email if there's a burning question that you think I might answer.
As to you in the audience, you'll receive an evaluation in your email. Please fill it out to help us plan for future events. We do have educational events at the Center for Women's Health Research throughout the year. 2 virtual events coming up are the Let's Talk Conversations about Women's Health, focusing on heart health on Thursday, February 18th, and our annual Women's Health Symposium, which is a CME event for healthcare providers, on Saturday, February 27th. And I think I will wrap up and say thank you again. We are getting excited about hopefully having our national conference this summer, at the end of the summer. Time will still tell about whether it will go forward given the times. You can learn about all of our events on cwhr.org. That's our website. We've worked hard on making it up to date, and we hope you'll take a look at it. Thank you again, Dr. Gabow, and thank all of you for tuning in. We will see you soon, hopefully.